Innovation, Automation, and Artificial Intelligence. We welcome you, ma'am. The moderator for this session will be Dr. Soumya Jain. She is a senior resident at RML Hospital. The case will be presented by Dr. Preeti, who is a postgraduate student at RML Hospital. Over to you, ma'am, for the proceedings of the session.
So, good morning, everybody. So I think we'll start with the case presentation first. So over to you, Dr. Preeti.
Good morning, ma'am. Good afternoon. Today I'm going to
please use the full screen. Yes.
Good morning. Today I'm going to present a case of a 4-year-old male child from Ghaziabad. Informant his mother. He presented with complaints of defect of proof of mouth since birth, difficulty in feeding since birth, difficulty in speech since 2 years of age. History of presenting complaints. He was born with a defect of roof of mouth. He had history of feeding via spoon and katori since birth and dribbling of saliva. He also gave history of difficulty in phonation and difficulty in pronouncing certain sounds such as P, T, K, D, S, and sh associated with a nasal twang. Past history. Child had history of difficulty in suckling and breastfeeding. He had history of nasal regurgitation of feeds, history of nasal twang in speech since 5 months of age, and delayed development of speech. He also gave history of recurrent upper respiratory tract infections, cough and cold 1 to 2 episodes every month, for which he had taken treatment on OPD basis. There was no history of breathing difficulty or hospital stay for the same, and the last episode of upper respiratory infection was 6 weeks back. He also gave history of multiple episodes of ear infection, last one being 2 months back, which got resolved on medication, and there's no hearing impairment at present. Birth history. The delivery was full-term normal vaginal delivery in hospital. He cried immediately after birth and was given to mother after birth. There was a visible defect of palate at birth. Developmental history. Development of speech was delayed, and all other milestones were achieved at appropriate age. Immunization history. He was immunized up to date as per the National Immunization Program. Examination. General physical examination. Child was active, alert, and sitting comfortably. There was no pallor, icterus, cyanosis, clubbing, edema, or lymphadenopathy. He was afebrile. Heart rate was 94 beats per minute regular. BP was 90 by 60 millimeters of mercury. Respiratory rate 18 breaths per minute. His height was 100 centimeters and weight 12 kgs. Veins were visible on bilateral dorsum of the hands. Airway examination. The external nares were normal. There was no nasal discharge or crusting. Mouth opening admitted 3 fingers, and there was a midline palatal defect of approximately 3 centimeters involving the alveolar ridge and both soft and hard palate. There was no neck deformity or restriction of neck movements. All other systemic examination, respiratory system, cardiovascular system, abdomen, and the central nervous system, all the examinations were within normal limit. Summary. 4-year-old male child presented with midline incomplete cleft palate, difficulty in feeding, nasal regurgitation, difficulty in phonation, delayed development of speech, multiple episodes of upper respiratory tract and ear infection, not associated with any other congenital anomaly, and admitted to hospital for palatoplasty. Diagnosis. 4-year-old male child with midline incomplete cleft palate and no other congenital anomalies. Thank you.
So Dr. Preeti, coming to your diagnosis, you have mentioned the word incomplete cleft palate.
Yes.
So what led you to the diagnosis of incomplete cleft palate, and what are the other types of cleft palate which you might come across?
Ma'am, we've diagnosed the cleft palate in this child as incomplete because there was involvement of the soft palate and hard palate, but not the entirety of the soft and hard palate, and there was no involvement of the uvula also. Ma'am, the cleft palate can be incomplete, complete, and unilateral, bilateral, pre-palatal, post-palatal, and submucosal. Ma'am, in complete cleft palate, there will be an entirety of the soft palate and hard palate involvement along with the uvula. And the pre-palatal and post-palatal cleft palate are, pre-palatal will be anterior to the incisive foramen, the structures, and in post-palatal, the structures posterior to the incisive foramen will be involved, that is the soft palate and hard palate. And in submucosal, there is a bony defect present in the cleft palate, but there's no mucosal involvement now.
So what is the relevance of this for an anesthesiologist?
Ma'am, ma'am, we have incomplete cleft palate and incomplete and cleft depending on the size of the defect, ma'am. It can there's a connection between the oropharynx and ma'am nasal cavity. So during feeding of the child, there can be regurgitation of feeds, and the feed can get into the airway, resulting into upper respiratory tract infections, ma'am. Because of the eustachian tube connection, it can lead to ear infections also, ma'am. And if multiple middle ear infections are there, the child can also have a hearing loss, ma'am. Ma'am,
Anything related to your laryngoscope? What will happen when you introduce the laryngoscope for a laryngoscopy? What happens
during laryngoscopy, the laryngoscope can get impacted into the defect, and it can hamper the visualization and also damage the underlying soft tissue, ma'am.
Right. So you should really know what is the defect type and how much is it, because it's going to affect your you are more cautious that which patient is going to have more incidence of upper respiratory tract infections. And secondly, you know how much difficult your laryngoscopy is going to be, right?
Yes.
So you had this child, a 4-year-old child, and from the history, it was very much evident that the child has a cleft palate. Now,
Yes.
if I focus on the age of the child, don't you think it's a late presentation? The child is a first visit to the hospital, or had
Ma'am, I'm really sorry, but your voice is getting cut. Ma'am, can you please repeat the question? Ma'am, had to
okay.
check. Ma'am.
Can you hear now?
Yes, ma'am.
Can you hear now?
Yes,
okay.
ma'am.
So I was asking that the child's age is 4 years.
Yes, ma'am.
So is it that the patient, is it a late presentation? What do you think? What is the right age when generally children come for the surgery?
Ma'am, the cleft palate is diagnosed at birth only during examination, but for the surgery, ma'am, we usually prefer 12 to 18 months of age so that there's no speech impairments. Ma'am, we can prevent speech impairments in children. Ma'am, the child we have from 4 years of age, he has presented late, ma'am.
Okay. So what is generally, you said it's 12 months that the child is operated. Is there
Yes,
any redo surgery? Is there any age where they want to do a redo?
Ma'am, we can do the surgery in 2 stages. In first, we can first repair the soft palate to improve the speech at 12 to 18 months. And then, ma'am, hard palate can be repaired up to 4 to 5 years of age to allow the palate of the child to grow properly, ma'am.
Yeah, so it is very important. Sometimes the parents do not give you a history of prior surgery. So if you find a child of 4 or 5 years, you should be asking straight or direct questions to the parents,
Yes.
right? That if they have had a cleft lip repair or they had any other surgery related to the same. Because if the patient developed any complication during that time, then it might be a warning bell for us that we need to be extra careful. So this is the first surgery in your child, right?
Yes, ma'am.
So after doing the PSC, after doing the examination, you have just found out that he doesn't have any congenital abnormality. He's just a child with no upper respiratory tract infection at present. Now, suppose he had a URI at the time of your examination. What
Yes,
would
ma'am.
you have advised?
Ma'am, we would have to postpone the surgery by 4 to 6 weeks, ma'am, because we want the upper respiratory tract reactivity to decrease, because it will complicate, ma'am, during the intraoperative period. Ma'am, we'll ask if they've got it admitted, ma'am, we'll ask them to start antibiotics, ma'am, the nebulization of the child, ma'am, so that the symptoms can get
Actually, that depends. You know, sometimes the mother says that, you know, it's just a running nose. So whenever you have an upper respiratory tract infection, you have to be very cautious, because these children are going to be at risk of URI, repeated URIs. You can't keep canceling them for 6 weeks. And probably 6 weeks is a very long time. You have to assess, is it only a nasal discharge? Is it just sneezing? Or does the child have a lower respiratory tract infection? So it is very important for you to differentiate between the upper respiratory rhinitis or just a nasal discharge from a lower respiratory tract infection. Because if it's just a running nose, then which is just mild, you don't need to wait for 6 weeks. Probably you can wait for 2 weeks.
Yes,
Right.
ma'am.
And if it is you are more cautious when you hear creps, when you hear wheeze, right, and the child is coughing mucopurulent secretions.
Yes, ma'am.
That is when you really have to start the antibiotics. That is when you have to send them to the pediatric medicine, and that is when you have to really wait for 6 weeks.
Yes,
So
ma'am.
URI is a very, when you ask the mother also, sometimes the child has, but she doesn't give history. Sometimes the child is not having, but she's extra cautious mother. So accepting a child or rejecting a child based on URI has to be a very graded decision, which has to be made by the anesthesiologist. Now, the
Yes,
second,
ma'am.
now what will you order in the after your PSC? What are you going to order? What investigations you will order? And what other preoperative advice you will give to the child before the child is posted for surgery?
Ma'am, we'll preoperatively we'll order for investigations that are the complete blood count, ma'am, the urine routine microscopy, ma'am, bleeding time and clotting time, and blood grouping and cross matching, ma'am. And because since these kids have difficulty feeding, so he could have malnutrition, ma'am, and the hemoglobin of this child could be low. So, ma'am, we'll have to see the hemoglobin levels. Ma'am, to rule out any active infection in the child, we'll have to see the total leukocyte count. Ma'am, the routine microscopy will also help to rule out any active infection in the patient. Ma'am, bleeding time and clotting time will help to rule out any congenital hemoglobinopathy if the child has. And ma'am, we'll have to order a blood group and cross matching in case of any blood loss we have, ma'am, intraoperatively. Ma'am,
Actually, different hospitals, they have a little different approach to ordering the investigations. Like complete hemogram and requirement of blood cross matching is universal, right? Everybody does that. Now, there is a difference when it comes to routine urine microscopy and when you talk about the blood BTCT, right? The bleeding time and the clotting time. Now, what is the practice in your center? Because in our center, we do not ask for any of the investigations like a BT or a CT or a routine microscopy of the urine. We are just worried about, okay, because in India, there's a lot of anemia, and because these children generally have less feeding. So we ask for a hemogram, that's all. So the take home message is that we as anesthesiologists probably may or may not ask for urine routine microscopy and BTCT depending upon your hospital approach to the patients or your hospital policies. So like in our center, we are just asking for hemoglobin. That is the order which is put by the anesthesiologist. It depends upon the surgeon if he wants to get any other investigation for his own surgical reasons. So it's really variable. It could be possible that in your center, you are routinely writing are you routinely writing BTCT? You write as a pre-anesthetic order?
Yes,
okay.
ma'am.
So it varies from centers to centers. We, in our center, do not ask for BTCT and we do not ask for routine microscopy because that is our hospital policies.
Yes,
right. And so you have cleared the patient. So what instructions are you going to give to the mother?
Ma'am, we'll give, ma'am, in the instructions, we'll tell her to keep the child adequately nil per oral, ma'am. 2 hours for, ma'am, clear fluid, 4 hours for breast milk, and 6 hours for, ma'am, any light meal, ma'am.
So she's going to ask you that my child is 4 years and he takes that, those powdered milk. So what are you going to say for the powdered milk? Breast milk to the child?
Ma'am, 6 hours for.
Okay.
Ma'am, 6 hours for powdered or any formula milk, ma'am.
Okay.
Ma'am, or in any other processed milk. Ma'am, then we'll take a written informed consent for the child, ma'am, and arrange adequate blood products, ma'am. Blood for the child for intraoperative.
Okay. So you come in the morning. How do you prepare your OT? It's the first case. It's your pediatric case, right? So how are you going to prepare your OT?
Ma'am, first we are going to maintain an ambient OT temperature for the child since he's a pediatric age group. Ma'am, the temperature has to be 27 to 28 degrees Celsius. Ma'am, we'll arrange warm blankets, ma'am, warm beer huggers, warm IV fluids, ma'am, with pediatric burette set. The anesthesia machine has to be checked with with pediatric airway circuit, ma'am. We have to keep emergency drugs for the pediatric weight of the child. Pediatric ambu bag, defibrillator, ma'am. We'll also keep a difficult airway cart ready for the child, including video laryngoscope, pediatric fiber optic, pediatric, any intubating laryngeal mask airway, and an alternate supraglottic airway device in case of any difficult intubation scenario, ma'am. We'll also keep, ma'am, adjuncts to airway adjuncts and stillid, bougie, and an alternate sized direct laryngoscope and an alternate size of, ma'am, our tube also.
Yeah. What I would like to tell you, because your child does not have any other congenital abnormality.
Yes,
So just because there's a cleft palate, I'm anticipating that I will have a little difficult laryngoscopy. My blade is going to be, getting stuck into the cleft palate. So probably I need some gauze. So I think
yes,
the most important thing which I want is gauze, right? So that I can cover the palate when I introduce the laryngoscope. I do not anticipate, and the incidence is very, very low of any difficult intubation in a simple cleft palate. So I am not going to arrange for anything, right? But I am going to be aware of the fact, like I am for any other OT, that what is available to me and where is it placed, right? So if you need a CMAC or if you need a fiber optic, you don't need to tell the technician to open it from the lock and key and keep it in your OT. Because a simple cleft palate is just like any other pediatric case, and except for covering the palate with the gauze, I'm not going to expect any other difficulty in intubation. Had it been a Perry-Robin syndrome with a cleft palate or any other syndromic child, I would have been more cautious. So
yes.
in this case, I will just make sure that I have gauze on my anesthesia workstation so that I can cover the palate. But and I will be aware of the equipment as an anesthesiologist, whatever is available if I land up into any crisis.
Okay.
Right? I would just advise that in any complex, whenever you are working, even if you have a simple case, but you should always be aware of what is available in your complex whenever you start a case, right?
Yes.
Yeah. And do you think the 4-year-old child is going to come with you inside the OT?
Ma'am,
What is
kids.
your plan? What is your plan for it?
Ma'am, in our institution, we usually call the mother along with the child, ma'am, inside the OT. And once the child is induced, then we send the mother out, ma'am. Ma'am,
So the child doesn't cry with the mother? The child can be angry with the mother and hitting and kicking the mother. Then why are you forcing me to go inside the OT? It is very much possible. So what are you going to do? What is your plan?
Ma'am, we can pre-medicate the child with oral midazolam, ma'am, 0.5 milligrams per kg, ma'am.
Okay, and he spits out that midas also. He spits it out because he's 4-year. He's not
Ma'am,
a
we can
small.
use intranasal midazolam 0.3 milligrams per kg, ma'am, for the child.
What are the other techniques of pre-medication? You have mentioned about midas, and you have mentioned about 2 different routes. You have mentioned about the route that you can give oral with honey, and the second you have told me is with a intranasal, with an atomization device, right? You need an atomizer. So do you have an atomizer at your institute?
Ma'am, we're giving intranasal sprays, ma'am. It's through an atomizer device only, ma'am.
Okay. And what are the other drugs which can be given with an atomizer?
Ma'am, we can give, along with midazolam, ma'am, we can give dexmedetomidine, ma'am, melatonin.
Okay.
Ma'am, we can also give oral ketamine as an alternative if you want, ma'am, in a child.
Now, you have done everything, and the child is a very stubborn child and is beating and pulling at everybody. So what is the last thing which was done in previous days that you want to do. What is a stunning dose of ketamine? How do you give a stunning dose of ketamine for pre-medication? You stun the child.
Ma'am, we give 5 to 7 milligrams of milligrams per kg weight, intramuscular.
Yes, that is
Intramuscular,
stunning
ma'am.
dose. Yes, that is the stunning dose of ketamine, and you
Yes,
have given it intramuscular, and you quickly bring the child inside, right? So
Yes,
you, whenever you do a pediatric case, it is very, very important for you to pre-medicate a child who's looking very cooperative at the first meeting with you is not going to be cooperative when he's going to come inside the OT. So never come in this. We have lots of residents, when we meet them in the morning, they say कि मैम कल मिले थे, कल तो बड़ा अच्छा था, बड़े प्यार से बात कर रहा था, आज ही
Yes,
सुबह रो रहा है, right? So you have to be very, very careful. वो child, and 4-year-old child is the child who has maximum separation anxiety.
Yes,
right? 6 months के बच्चे को तो प्री मेडिकेट करने की जरूरत ही नहीं है, right? थोड़ा बड़ा हो, 10 years का हो, 11 years का, the child will still understand if you explain him something. A 4-year-old child is most difficult to manage. Right? So you brought the child inside. Now, your child, you brought him inside, right? And you have brought in using your own technique, है ना, with the mother. You brought the child with the mother. Okay. So after that, what do you plan?
Ma'am, our plan of anesthesia is to induce the child under general anesthesia with endotracheal intubation and controlled mandatory ventilation. We'll use, ma'am, inhalational induction with sevoflurane. We'll, ma'am, first attach all the standard ASA monitors to the child, ma'am, including the ECG, non-invasive BP monitoring, and pulse oximeter. But then we'll prime the circuit with sevoflurane, and after we'll switch on the sevoflurane to 8%, and we'll form a proper seal with the mask. Once the child is under the effect of sevoflurane, we can then secure our airway with a south pole tube under direct laryngoscopy, and then we'll once the bilateral air entry is checked and confirmed, we can secure the tube in midline over the lower lip, ma'am, to maintain cosmetic symmetry, ma'am.
Okay. And so, do you use nitrous when you are using inhalational induction, or are you using? No. When you took the child inside, and you are using inhalational induction, right?
Yes, ma'am.
So when you are giving inhalational induction with sevoflurane, are you using nitrous also as a carrier gas, or what is the practice in your center? Do you use 100% oxygen?
Ma'am, we use 100% oxygen and sevoflurane at 8%, ma'am.
Okay, so you do not use nitrous. You want to be careful. Okay, and after that, after what is the second step you do after inhalational induction? After inhalational induction, you know that your child is induced, the child is on spontaneous ventilation. So what was this step after that?
Ma'am, we'll secure our airway. Ma'am, we'll secure our airway with the south pole tube, ma'am, under direct.
You haven't put the cannula.
Ma'am, we first secure an IV cannula, and then after giving.
That is the most important thing. After your inhalational induction, you keep the child still spontaneous, right? You don't want to give positive pressure ventilation and lose control over your airway. So you will be putting a cannula, right? Now your child has a very difficult cannulation. It's a very chubby child. Suppose you have a very chubby child, very difficult cannulation. So what are the other areas you're going to see?
Ma'am, for IV cannulation.
Yes. IV cannulation is the second biggest problem which you fail in pediatrics. Cannulation can be very, very difficult if a child is chubby, or otherwise also in some children cannulation becomes very difficult.
Ma'am, we'll first check all the forelimbs if we can try to form a vein. If it's not possible, ma'am, we can have an alternative of external jugular vein also, ma'am, to cannulate.
Okay.
Ma'am, since it's comparatively easier, ma'am, and more easily found, ma'am.
Okay. So after the cannulation, you have talked about the endotracheal tube.
Yes, ma'am.
Now, what kind of endotracheal tube do you want for a cleft palate or a cleft lip?
Ma'am, we use RE tube, Ringidaire Elvin tube, which is the south pole tube, ma'am, so that there's a surgical access to the surgical site for the surgeon, and we can fix our airway over the lower lip away from the surgical site, ma'am. So
what are the problems of the RE tube? You have told me the advantage. The advantage, you have told me that it doesn't interfere with the surgical airway. So what are the problems with the RAE tube?
Ma'am, with the South Pole tube, ma'am, specifically the distal length of the tube is fixed, which can for different children, ma'am, the length can be not be appropriate for the size of the patient, ma'am. Ma'am, it also leads to difficult suctioning of the tube because of the bend in the tube, and ma'am, there's increased airway resistance in the tube because of the curvature, ma'am.
So do you want to use a cuffed tube or an uncuffed tube? And what size are you going to tell your technician to keep ready?
Ma'am, for a child, ma'am, since his weight is 12 kgs, we are going to keep a tube of size 4 and an alternate of 4.5, ma'am. And we'll use a cuff tube, ma'am, to prevent any sort of any trickling of secretions or blood from the surgical site into our airway.
Yes, so you should use always a cuff tube, and you have to keep all sizes above and below 0.5 above and below available, because sometimes you have to do multiple insertions, because if you put a cuffed, sometimes because of the cuff it doesn't pass the glottis, right? So you should be very cautious that what size tube you're going to put.
Yes.
And after intubation, how are you going to check whether the tube is not endobronchial or your tube is not coming out?
Ma'am, for endobronchial intubation, we'll check bilateral air entry, ma'am. It has to be equal, ma'am. If it's gone into the right bronchus, the air entry will be more on the right side compared to the left side, ma'am. And followed by, ma'am, we have to check for any accidental extubation intraoperatively. We have to keep monitoring the peak pressures, the end-tidal CO2, ma'am, and the air entry.
What is the positioning? What position are the surgeons going to operate a cleft palate? What is the position?
Ma'am, rose position.
So what is that?
And the child is supine with a shoulder roll and the head in extended position, ma'am.
So what happens to an endotracheal tube when you flex the head, and what happens to the endotracheal tube when you extend the head?
Ma'am, if on flexing the tube can, on head flexion, the tube can get, ma'am, kinked, and on the extension of the head, there can be an accidental extubation of the tube, ma'am.
So flexing of the head just doesn't cause kinking. The flexing of the head can cause the endotracheal tube to move a little inside, and a tube which was in the normal position, you could hear bilateral air entry. After flexing, the tube could become endobronchial. Now, in your scenario, flexion is not being caused by the surgeon. It is the extension which is worrisome. Sometimes what the residents do is they just make the they use an uncuffed. This is more problem when you're using an uncuffed tube, right? So probably you tried putting a cuff tube, but the cuff was, it was too tight in the glottic opening, and then you decided to put an uncuffed tube. There is, you have to sometimes weigh the situation, which tube is best suited. So suppose you put an uncuffed tube and you just crossed the glottic opening and your tube was just a few millimeters inside. Now it is a big possibility that when you position the child in extension, your tube could accidentally come out. Yes, right? So you have to be very careful for that. And after putting the patient on the ventilator, what mode are you going to use? Pressure control or volume control?
Ma'am, you're going to use volume control mode, ma'am.
Why do you want to use volume control?
Ma'am, because, ma'am, in case the in volume control, we'll be able to see if there's any kinking of the tube because of the retractor or any other caused intraoperatively. Ma'am, we can see if the tidal volume is being delivered or not.
So what are you going to watch? What are you going to watch in that? Are you going to watch the tidal volume? So what are you going to watch?
Ma'am, the end tidal CO2 and the tidal volume, ma'am.
No, you're
and
going
peak
to
pressure.
watch. Yes, that is very important. The most important monitoring which has to be done in cleft palate is your peak pressures. Yes. What are the situations when your peak pressures might increase? What are all the situations?
Ma'am, the tube could be getting kinked because of the retractor that, ma'am, we put intraoperatively, Digman retractor, ma'am. Yes. Ma'am, it can also be because of any blockage of the tube, ma'am, because of the secretions, ma'am.
Yes. And it could be when your child develops a spasm, right? So you can always have a spasm. And so it is very, very important for you to, after intubation, you must know what the pressure is, peak
Yes.
pressures. And suppose your peak pressures come out to be 12 or 13, right? And after putting the retractor, they are going to increase. There is going to be a definitive increase. But if it increases to 15, so you don't need to worry, right?
Yes.
But if it goes to 21 or something like that, then you need to communicate it to the surgeon.
Yes.
That is very, very important. Some amount of increase in pressure, like from 13 to 15, is expected.
Yes.
But a big increase, like an increase to about 21 or 22, is not acceptable, and that has to be communicated to the surgeon, right? Okay, so now your surgery went on uneventfully, right?
Yes.
So what do you want to do at the time of extubation? How are you going to plan your extubation for this child?
Ma'am, once the surgery is completed, we'll, under direct laryngoscopy, we'll do a light suctioning of the surgical site to see if there's any active oozing of blood or secretions at the site, ma'am, and if there's any swelling of the tongue or the airway, ma'am, so that in case if there's any swelling or any active oozing of blood, we'll postpone our extubation till the swelling subsides, ma'am. But if there's no bleeding and no swelling of the tongue or the airway, ma'am, we can plan our extubation when the child is fully awake and in full control of his airway reflexes, ma'am.
Okay, so what do you do after? What are the few things that the surgeon keeps telling you at the time of extubation? What do you think the surgeon wants?
Ma'am, the throat pack has to be removed, ma'am.
Yeah, that is your communication. That is
communication.
when the surgeon completes the surgery, it is for you to ask the surgeon specifically and not forget at all that have you removed the throat pack?
Yes,
Yeah,
ma'am.
and the last step which the surgeon generally does is he removes the throat pack and he does a suctioning himself. So if
Yes,
your
ma'am.
surgeon is doing the suctioning, you can coordinate with him at that very moment, right? And
Yes,
see for
ma'am.
yourself when he is doing the suctioning that how the field is, right?
Yes,
So that you don't have to do suctioning again and again, because they're very, very they want you to be very, very cautious of the sutures which they have placed. They don't want you to disturb any of the sutures which they have placed, and they want the extubation to be done very, very smoothly. They don't want a crying child, or you landing up in a situation where you have to re-intubate the child, or you have to give positive pressure ventilation, or you have to put an oral airway.
Yes.
Because if you put an oral airway, if you do anything like that, then the entire purpose of doing the surgery is lost.
Yes.
Right? So you
Yes.
have to plan in such a way that your child is fully awake, so that some amount of secretion is going to be there. Some amount of oozing will be there after the surgery. It is not going to be a zero oozing area. Some amount of oozing is always going to be there. So you want your child to be fully awake so that he can spit out, cough out, right?
Yes.
And there is no secretion going into the larynx. But you don't want a child who's crying so that he takes out his cannula and he's just trying to put his finger into his mouth. You don't want that kind of an irritable child. And you do not want a child who is so much deep that he's not able to maintain and you have to put an oral airway, right? So that deciding that plane of anesthesia is most important. So are you going to keep the child supine after extubation?
I'm going to keep the child in lateral position so that the secretions do not go into the trachea, ma'am.
Now your child,
in the post.
What did you plan for the post-op pain management? What did you give intraoperatively to the child? Which opioid?
Ma'am, we'll give fentanyl, ma'am, 1 to 2 mics per kg at the time of induction, ma'am, and then we'll maintain, ma'am, at 0.5 milligrams per kg, ma'am. And post-operatively, ma'am, I'll give paracetamol, ma'am, 180 milligrams, 15 milligrams per kg for the child. Okay. And ma'am, we can also adjunct it with greater palatine nerve block so that the patient is pain-free post-operatively, ma'am.
Okay, great. So any other questions which we have or you have? Because I think Dr. Soumya is going to summarize in the end. So how much time is Soumya needing for the summarizing? How much time?
I just want 5 to 6 minutes.
Okay. So we can shift over to Dr. Soumya so that we stay on time.
Okay, thank you, ma'am. Thank you, Preeti. I'll
Thank
be
you, ma'am.
summarizing the case of cleft lip and palate for you. Okay, coming to the incidence, cleft lip with or without palate is 1 in 700 births. For cleft palate, it is 1 in 2,500 births. Asians are the most susceptible ones. Boys are more affected. Isolated cleft palate are more often in girls. 75% of the clefts are unilateral and left-sided are more common than the right ones. Coming to the genetic association, the genes associated with orofacial clefting is MSX1 and TBX22. Cleft palate genes are located on chromosome 14, and for cleft lip, it is chromosome 1q locus A. The development of upper lip and palate is completed by 7 and 9 weeks. So maternal smoking at this time greatly increases the risk of cleft lip and palate. Other etiological factors associated might be alcohol, poor nutrition, viral infection, diabetes, various drugs, and teratogenic agents. Coming to the classification, as we have discussed, for cleft lip, it can be unilateral or bilateral, complete or incomplete. Complete involves the entire lip going into the nostril. And for cleft palate, the classification is pre-palatal and post-palatal based on the location of incisive foramen. And we can also have submucosal clefts. Coming to the embryology, the clefting of lip and nostril occurs due to failure of nasomedial process to merge with the maxillary prominences, while cleft palate occurs due to hypoplasia of palatal shelves or mistiming of the palatal shelf elevation. The various syndromes can be associated with cleft lip and palate, most common being Pierre-Robin syndrome. Others are Treacher-Collins, Down syndrome, Klippel-Feil, Stickler, fetal alcohol, and Goldenhar syndrome. Vectoral anomalies might also be associated with cleft lip and palate. In Pierre-Robin syndrome, we can have micrognathia, glossoptosis, ASD, VSD, PDA. In Treacher-Collins, we can have maxillary and mandibular hypoplasia, retrognathia, kyphosis, narrow nasopharynx, hearing difficulties. In Goldenhar, we can have hemifacial microsomia, micrognathia, vertebral hypoplasia, and various cardiac abnormalities. The surgical correction follows Millard rule of 10, which suggests that the hemoglobin should be more than 10. Age of the patient should be more than 10 weeks and weight should be more than 10 pounds. So most commonly cleft lip repair undertakes at the age of 3 months, but now it is said that we can do it as soon as possible. For cleft palate, it should occur at the age of 9 to 12 months, that is before the speech development. Various anesthetic concerns are pediatric population, associated congenital anomalies, chronic airway obstruction, anticipated difficult airway and shared airway, recurrent respiratory tract infection, malnutrition, dehydration, anemia, and exposure to multiple surgeries. So the patient should undergo complete medical evaluation including the various congenital anomalies which might be associated. Potential airway difficulty can be seen in Pierre-Robin, Treacher-Collins, Goldenhar syndrome. The child might have recurrent respiratory tract infection which have to be resolved before the surgery. Difficult laryngoscopy, most commonly seen with the bilateral clefts, and the incidence is 45.7%. Coming to the perioperative monitoring, we need a precordial steth, ECG, pulse oximetry, capnography, non-invasive BP monitoring, and temperature monitoring. For the induction of anesthesia, we can go with IV induction or inhalation induction, but if we are anticipating a difficult airway, we should go for spontaneous inhalation induction and a difficult airway card, including the laryngeal mask airway, the pediatric fiber optic, and video laryngoscopes should be ready. These are the various ET tubes. The most commonly being used is the South Pole tube. We can also use a flexometallic or the Oxford tube. This is the position of the patient intra, which is called the rose position, where the patient is supine with the shoulder roll and head hyperextended. And as we have discussed, accidental extubation can occur during this position, so we need to take care of that. Intra-op anesthetic concerns would be placement and opening of the Dingman mouth gag, which can cause compression, kinking of the tube, and even accidental extubation. Make sure that the pharyngeal pack is in situ to prevent any aspiration of blood and secretions. This we can see the Dingman mouth gag in situ. Another intra-op concern is the infiltration of adrenaline by the surgeons. Make sure that the concentration is 1:2 lakh and dose should be less than 10 microgram per kg. Maintain normovolemia, normothermia, and maintenance of anesthesias with inhalation agent, oxygen, nitrous, and top-ups with short-acting opioids and muscle relaxant. For the perioperative pain relief, we can give a combination of short-acting opioids, paracetamol, NSAIDs, peri-incisional infiltration. For cleft lip, we can give an infraorbital nerve block, and for cleft palate, we can give a bilateral greater palatine nerve block. The infraorbital nerve supplies the lower aspect of eyelid, upper lip, medial aspect of cheek, and lateral aspect of the nose. The greater palatine foramen is situated medial and anterior to the second upper molar. Nerve is blocked on either side as it exits the foramen with 1 ml of 0.25% bupivacaine. There are two mainly post-operative concerns. One is the bleeding, other is the airway obstruction. So the airway obstruction occurs mostly due to the reduction in size of the airway after surgery. And the secondary reason is the swelling of airway, uvula, tongue due to Dingman mouth gag. So to prevent that, we can give intraoperative dexamethasone. Then at the end of surgery, inspect the oral cavity under direct laryngoscopy, and gentle suctioning should be done, rule out any oozing or bleeding. Heavy silk tongue sutures can be secured to face to allow a rapid opening of the airway. After extubation, patient should be nursed in lateral position for drainage of any blood and secretions, and extubation should be done only when the child is fully awake. If the surgery is for more than 2 hours, we can ask the surgeon to remove the mouth gag for a few minutes to allow tongue perfusion. We can also use a nasopharyngeal airway for in case of any airway obstruction. Thank you.
Thank you so much, Dr. Preeti and Dr. Soumya. Thank you so much. Both of you presented very well. I don't think we have any questions in the chat box.
No, ma'am.
So I think we can conclude, if you people permit.
Yes.
Okay, thank you so much.
Thank you so much.
Thank you so much, ma'am. Thanks for being part of APPEC2023. Thank you for your valuable contribution. And,
Thank you,
thanks to Dr. Soumya and Dr. Preeti.
Thank you, sir. Thank you, ma'am.
So we'll move on to the next session. May I invite the chairperson of the next session? So next session will be chaired by Dr. S.K. Singhal. Sir is senior professor and head of the Department of Anesthesia and Critical Care. He is the nodal officer COVID-19 at PGIMS Rohtak. Sir is in charge state-of-art Dharwantri Apex Trauma. He is the chairman of UMC UHSR. He is the chairman of the Modular OT Complex. Sir's area of special interest are difficult airway, ethics in medical practice, critical care, and communication skills. We welcome you, sir. I hand over the proceedings of the session to sir.
Are you able to hear me?